Speaker Gingrich, thank you for being at Dartmouth today. I'm Dr. Ira Byock. I direct the palliative care program here at Dartmouth-Hitchcock. We applaud innovation and metrics at this institution and have contributed to it. One of the most disturbing metrics in healthcare is that 100% of Americans still eventually die.
I was going to ask you guys about that.
And we're working on it. But that over 50% of Americans still die in hospitals and 20% die in ICUs.
Right.
Our field of palliative care has applauded your statements over the years, particularly after your father-in-law died at Gunderson Lutheran in Wisconsin in 2006, about the personalized, individualized care that you received, and it was patient and family-centered, something that we take very seriously at this institution. We've been trying to implement that innovation here, with the assumption that there's nothing more intimate and decentralized, to use your terms, as that intimate conversation between doctor and patient. Your writings and your statements really applauded that concept right through April of 2009, but in the kerfuffle that surrounded the healthcare debate in August or the summer of 2009, you seemed to switch positions and actually support Governor Palin's characterization of the clause in the health care bill that would have Medicare support those intimate conversations of doctor and patient around end-of-life preferences, her characterization of it as a death panel. I just want to ask you to please clarify the record, and please tell me that you don't believe that those intimate conversations and advanced care planning in some ways represents coercion or death panels.
No, but you just described two totally different things. That's exactly why I reinforced what she said.
I don't understand.
When we were here for the Dartmouth debate, on that very day, a panel said that in fact we don't need to use the test for prostate. And they issued a report saying it's not necessary. I get an immediate email from Andy von Eschenbach, who had been the provost at MD Anderson, the largest cancer treatment center in the world, the head of the National Cancer Institute, and the commissioner of the Food and Drug Administration. He says, this is a bureaucratic decision that is nuts. It is done by a panel that had nobody on it who was a cancer specialist and nobody on it who was a urologist. Now, that's what I'm referring to. The idea that a group would say, because this was a group decision, on balance, there are certain risks involved with this test, and therefore it's not really a very useful thing to do. But for 10 to 12% of males who have an aggressive form of prostate, it is in fact a very useful test and may well save their lives. Now, my point is, I am totally for the Gunderson Lutheran model, which is decentralized, not budget-related, involves no statement from the hospital what a good or bad treatment is, and has the family and the doctor have a personal, intimate conversation about the appropriate context. They do exactly what you're talking about. They have palliative care. They have an electronic health record so everybody knows what the final decisions are. They work things through with the family and with the patient. The experience we had with Callista's father was a very sensitive, very caring thing. The entire team gets it, so every nurse got it. I mean, it was a very, very emotional process to go through. I am willing happily to support that and to suggest that that should be something supported by Medicare. If it's done in a totally decentralized way with no bureaucracy from Washington defining the terms. But the second you start telling me, like the British model, that we're now going to decide what's appropriate for breast cancer and what's inappropriate as a group decision, arguing on statistics, and this is the danger of statistical data. Because personalized medicine may say that for you as a unique individual, this is exactly the right therapy, although for the next 1,000 people, it's not all that relevant. And I think it's very dangerous to start taking something as personal as health, which is stunningly complex, and start abstracting it into random bureaucratic averages based on statistical analysis.
So just to be clear, that clause had really said that Medicare should support and reimburse doctors for having that intimate conversation. And I think I just heard you to say that you actually thought that that was a good idea.
Having that funded so it happens at a personal level is terrific. Having any Washington bureaucracy start recommending what should or should not be appropriate and when they think statistically you should or should not allow people to die, I would fight to the end. I think it would be a terrible step in the wrong direction.
Thank you.